this lesson, I'm going to be explaining gestational diabetes and how you'll take care of this patient. So gestational diabetes is diagnosed in pregnancy at around 28 weeks gestation. This is the patient that's never been diagnosed with diabetes before, okay? So it's just gestational, somebody that's only diabetic in the pregnancy. This happens because the body can't respond to the increased insulin requirement that's needed. And then there's also insulin resistance occurring from the increased hormones. So we get resistance. Carbohydrate metabolism is also changing the insulin requirements. The fetus can make its own insulin. So the fetus can do its own. So it will secrete its own insulin to battle whatever the blood sugar is. The baby or fetus is getting the blood sugar or sugar from the mom. So the sugar crosses the placenta. Insulin does not. So because of this, the fetus is pulling the sugar from mom and can make the mom have low blood sugar and be more hypoglycemic. So a fun fact is that since the baby makes its own insulin but needs glucose, it's going to pull the glucose from the mom and make her more likely to be hypoglycemic. Another piece of this is that since so much sugar, if the mom's sugar is high, is crossing the placenta, because the mom has hyperglycemia, then the baby is going to make more insulin, right? It's going to increase the amount of insulin because the mom's sugar is high. And insulin is a growth hormone. So the high sugars make the baby secrete more insulin and the baby grows bigger because it's a growth hormone. So it's not necessarily the high sugar that causes it, it's the insulin that causes these babies to grow bigger. There are a lot of changes occurring on the maternal side. So in the first trimester, insulin needs go down, okay? So the body is working super hard to grow a baby. So the metabolism has sped up. So blood sugars are going to be lower. So we have more chances of being hypoglycemic. So insulin needs go down in that first trimester. Then in the second and third trimester, we have insulin resistance starting. So hormones go up and the insulin needs go up because we have resistance here. And that's why women are screened at 28 weeks because we're in this range of trimesters in between second and third trimester. So for this reason, they're screened then because we have an increased insulin resistance. So what happens after the baby's born? Right after delivery, those hormones crash and so do the insulin needs. So a mom that's been diabetic and needing to check her blood sugars throughout pregnancy and really was showing high blood sugars is going to no longer because the crash of the hormones. Usually the patient will get maybe one more blood sugar check, like a fasting the next day, and then be all done. And then for our urine, so we need to be watching during the prenatal visits. They're going to be getting a urine on the mom and checking for glucose and for protein. So what is happening with the newborn, with this mom that's gestational diabetic? So the baby is growing faster and larger, remember, because of an increased amount of insulin because of the mom's high blood sugars. So the insulin, our growth hormone, is making a baby macrosomic. So that's a baby that's over 4,000 grams. So that's over 8.5 pounds is macrosomic. Around, I should say 8 pounds, 8 ounces. Okay, so big baby. Keep in mind that the baby is growing faster and larger, but it doesn't mean that the baby is able to function earlier on the outside just because they are bigger. After delivery, we have blood glucose monitoring. Now, remember, this is for the newborn. So we want their blood sugar to be 40 to 50 is the range for a baby. That's a good blood sugar. So different than an adult. So 40 to 50 is our range. Remember, the baby, the reason why we're checking blood sugars, even though the mom's now no longer diabetic, that baby was getting all this sugar coming across the placenta, okay? So tons of sugar coming. So the baby makes more insulin. Then the baby's born, and this extra sugar coming across the placenta is no longer there, and we still have an increased insulin. So we have to be monitoring the blood sugars to make sure that they don't plummet. All right, our therapeutic management. So for therapeutic management, this is going to involve education on diet and exercise. We want to make sure that they are aware. For some of these women, this is a huge change that they've never had to deal with. So we don't want them going and running a marathon or anything like that, but just walking, getting good exercise, and then a healthy diet, low carb. If they are on insulin, then they're going to need to learn how to dose based on what their blood sugar is, and know what they're eating. So monitoring for complications, typical complications with diabetes. So infection, remember, they're still going to be more at risk for infection, hypertensive problems. They might be extra edematous, and then the proteinuria. So we're going to be monitoring for those complications. And then, of course, monitoring glucose for mom and then the baby after they're born. And then referral to endocrinology just to get them involved to help with their management. So our education, just in a little bit more detail here, we need to educate this mom on hypoglycemia and hyperglycemia symptoms. They need to know what that feels like. So just like a normal diabetic that's just been diagnosed, the kinds of things we're going to teach them. They need to know how to manage their blood sugar. So how often do they need to be checking it? If they are required to take insulin, then they need to know how to inject it, how much insulin to give, and then monitoring their glucose for logging them. So this will be really important because the doctors are going to want to see what the ranges are at different times a day to see what's working and what's not for them. And then our diet and exercise. So good food options for them. What kinds of exercise should they do? What are healthy food items? How to carbohydrate count, healthy snacks, things like that. Our nursing concepts for someone with gestational diabetes is going to be glucose metabolism, because we are dealing with diabetes and a patient and this is a big piece of it. And then education. Patient education is going to be huge because this patient just thinks she's pregnant and now has this diagnosis. So she's going to need education on blood sugar monitoring and what this all means. All right, so let's bring it all together and look at our key points here. So gestational diabetes mellitus is going to be only in pregnancy, okay? It occurs only in pregnancy. We have insulin resistance in pregnancy, so it's putting them at an increased risk. There's added weight in pregnancy, right? Because we're growing a baby, so that's going to also increase their risk. And then diet. So is that part of our treatment? So good, healthy diet, watching the carbohydrate count. And then insulin is going to be usually our treatment. Sometimes they can be treated just with diet and exercise. Make sure you check out the resources attached to this lesson and review the things that are going to make the diabetes worse and cause more complications. Now go out and be your best selves today. And as always, happy nursing.